model, and a Malapati 2 is her mother, and a Malapati 3 is her father. And a Malapati 4 is the cousin they don't talk to at family gatherings. Okay? Okay, well,
too few chromosomes.
Am I a dick or am I a dick or what?
I was like, have you copyrighted that? Am I going to see that in a textbook next month?
I'm going to look. I think I'm on the verge of taking stand-up comedy lessons, and it's going to really bother my wife a lot because I'm not going to stop talking.
Second city here.
I know, but I live in Milwaukee.
That's all right.
I have to go to a bar that provides shuttle service to Miller Park, the ballpark.
Yes.
Okay. All right, so here's the thing. So now we've got a great view, but what we're gonna do is if you're gonna teach this, you gotta give them a shitty view, and they have to do this. So if you're gonna model this, this is
That's
what's
a
called,
1.
That's a grade 1. This is a 2A where you see half, and this is a 2B where you see only the interretinoid notch, and this is a 3. Okay, that's a 3 right there. One of the major problems that this thing solves actually is not a poor view. It's a poor tube delivery. You've got a system for facilitating poor tube delivery. So what I'm going to do now when I come in is one of the major problems with using a device in which you're not going through the center hole like on his thing is that you don't leave the room for tube delivery. The way to fix that is with the index finger, you go into the mouth, and if the tongue is bulging over the laryngoscope, you simply push it over to the proper side, and you create the room to put the stylated tube in, okay? And so he's already got one on there, but it's like an uncuffed something.
Oh, okay.
Good. I'm going to come in under direct vision. I'm going to keep watching it until it disappears behind the base of tongue, and then my eyes come up to the video. And as I come in, I'm going to come in for a lane. I'm going to tube the goose, right? But with your device, I come back, and I begin to go on to the Flexa something later. And I'm gonna come into the right position because I'm in the wrong position to do this. I think what happened was the tube disengaged and they actually restricted the ability of the. Do you see? So one thing we just learned by doing this, it won't hurt the mannequin, it won't hurt the scope to do this, by the way, and I actually do this in real patients. Oh, thanks. Thank you for doing that. If this tube disengages prematurely, the flex mechanism doesn't work because the rigidity of the plastic stops it from working. So if this happens, you've got to make sure you teach the customer to lock this in here.
Right.
Okay, all right, let's go back to this. So we're going to get a perfect view. This is a hypercurved video laryngoscope, which means we're going to fail to place the tracheal tube. When I go to place the tube, because the stylet is not hypercurved or whatever, I'm going to tube the goose. But with your device, I'm going to go onto the flex lever, and as I come in, I'm going to actually trap the device against the anterior wall of the cricoid the thyroid cartilage. The thyroid cartilage surrounds this area. Right now this device is trapped and will not go any deeper. So what I'm going to need to do to make this work actually is almost tip it upside down to get it to go. I'm trapping in the interretinoid notch, the posterior commissure and larynx, okay? And I'm having a little bit of trouble getting past that. So what I'm going to do is I'm going to give myself a leftward turn, because what you just saw here was the phenomena of the gap between the leading edge of the catheter and the beveled edge trapping the right corniculate cartilage, which is those knobby things on the right. There's knobby things on the left and there's knobby things on the right. The knobby things on the right catch this leading edge on a routine basis, so the therapy for it is actually, as you begin to advance the tube, you have to actually turn to the right and come down, okay? So technique from the beginning. Going into crab stance, I bend my knees, I open this thing, I can put this in. And what I'm also seeing here is because of the versatility of this device might be, I don't know if I can, it's too much crap to hold in this hand, but what you could do is I could do this, I could do this, and I am a two-handed laryngoscopist. So now that I'm satisfied.
Assistant hands it.
Well, indeed, you know what I did was I did the laryngoscopy like this.
Yes.
And then,
Okay.
you see the maneuver I
the lightsaber technique.
Kind of, yeah. I mean, you know, I'm trapping against. If this thing were a bit longer, I don't know if it would help. I'm not telling you to change your device. I'm just telling you what I'm thinking.
Right.
This right corniculate is trapped. You see this? This is trapped. You need to understand that it's also sort of interretinoid notch, right corniculate trapped. I'm going to physically rotate the device. If there's tension as I'm rotating, it doesn't turn because it's trapped. So I have to actually back it up a little bit and then turn it, and then advance it. This is a motion that is very familiar to all men.
What about our female doctors?
They're not that good at it.
So, did you want to show them how they'll fail with this straight stylet?
Sure.
I don't have a stylet. I just have a bougie, but
Okay,
still.
all right, okay.
But this is, you need to let your customers fail with the tools that they have,
Yeah.
and then hand them your tool.
So I'm going to skip over the other thing.
So, I
There's-
see it.
There's other reasons you may fail. This is impossible. I can't get it. And I'm fixated on it, and I'm not looking at the monitors, and I'm only concerned about this.
And then I say, hey doc, can we let the patient have a breath?
And now we're like,
And so now we're re-oxygenating.
now we're
them.
angry, and now I'm angry.
Yes.
Now I'm angry, right? How can you get a bougie to work with this hypercurve video on your scope? How can you do it? You want to see how to do it?
Yep. Put a kiwi grip
you
in it.
know how to do it.
Okay, I'm going to show you something.
Is that the kiwi grip?
It is the Kiwi D. The D is for DuCanto, by the way.
I thought it was a DuCanto corkscrew.
Okay. Kiwi D.
All right.
All right, so we're going to give it a coup d'etat thing. Now here's the thing. How do you make this work? Is you really need a towel. So we're just going to use this. What you do is you basically make like a burrito, you know, like a wrap, and then when you're ready to use it, quickly take it out. Otherwise, it loses memory. Okay. Left turn in. Okay. Okay. All right. So, what is the problematic is that the plastic. We haven't gotten to the technology in plastic yet to set for the plastics to set the memory. It'll be there. It's a nanoscience issue, and the thing is that somebody has to ask the question. They have to ask the question: why do I want to change the properties of the plastic when it costs money?
Yes.
Well,
This is why.
The answer is because we need it.
Right. It may exist in some other industry.
Yeah.
We just haven't found it yet.
Now, just so I can tell you what's going on here, you got a 6.0 tube here. This is about as long as it gets, right? You're not changing this device, so one of the things I'm going to say is if I use a longer tube, like a 7.5 or 7.0, it's a 7.5. Let's see how much is sticking out. Not a lot, okay? Is the device really going to be able to perform with just, is this device appropriate for a 7.5? Is it appropriate for a 6.5? Probably. A 6.0, yes. And if you wanted to solve all the problems associated with this device, you pair it up with the Parker Flex tip tube, because the Parker Flex tip tube doesn't have this left cut leading bevel down hanging up. So,
Do you know what he's talking about?
Yeah.
Or do I need to get one?
No, I know.
Oh, you got him.
so I'm just telling you.
Yeah.
I'm telling you that this device, the way you have it configured, because it's of that length, is only really going to work reliably with a 6.0 or a 6.5. With this 7.5 tube, this actually is not going to function. Okay, you see it? It's not going to work.
Right.
The tube's too long. The only way to make this tube work is to physically take out scissors and cut it at 27 and move the connector down. And you can do that, but they're
You've modified a
most of-
manufactured product.
well, it's okay for physicians, but most individuals are not going to want to do it. If he's my physician extender, unless I say, this is what I want you to do, he follows my order, he does it. But if he's left to his own devices, he's just going to use a shorter, smaller tube. Is there a problem with small tubes? No. Is there a problem long-term in ICU? Possibly, but now we have ventilator modes that can do lung recruitment maneuvers and hold continuous positive airway pressure, so that smaller tubes aren't that big a problem, although they are a little bit harder to wean patients off ventilators with. And if they have a problem with that, the answer for them is to change it over an airway exchange catheter for a larger tube. And the other reason to do that, which I can't speak for ICU physicians, but the goo that gets on here, it not only just gets on there, but it collects bacteria and it forms a biofilm. And so if you want to know what VAP is, it's because basically you put a steaming pile of poo into the airway and it fermented and caused pneumonia.
Cheese.
You did. That's the deal, dude.
Yep. Yeah, you don't want ventilated
But
cheese.
back to the sales question.
Yes.
I say make them fail.
Yes.
Make them fail with their current tools,
Yes.
and then show them this.
Excellent.
Yeah. Yeah. Ideally, if you need a Parker, they're out of here already. But get a 6.0.
do you need one?
Give them a Parker Flex Tip 6.0.
I think
If
I'm
you-
gonna
or
have 7 high.
I'll give them a 7. Let's see if it works.
Yeah, I called Dr. Parker 2 months ago and he was packing up his office. I said, we're on our way to Cincinnati. I'd love to meet you. I said, sorry, my lease ends in 3 days.
Where's he going? Did he say?
Retired.
Well, his email doesn't work anymore.
Yeah.
I sent him an email.
I think he's bought an island.
He